Did you know lung cancer is the leading cause of cancer-related deaths worldwide? What's even more surprising is that two patients with the exact same type of lung cancer and even the same kind of treatment might still have very different outcomes simply because of who they are, their biological sex, or even their body weight. This was the question that caught my attention. How do patient intrinsic factors such as biological sex and obesity affect the success of life-saving cancer treatments? Here, I am focusing on non-small cell lung cancer, which makes up about 85% of all lung cancer cases. In the last decade, immune checkpoint inhibitors, drugs that unblock the immune system so that it can fight tumors, have transformed cancer care, but they don't work equally well for everyone. That's where patient-specific factors like biological sex and obesity come in, often overlooked in research, yet powerful predictors of who might benefit the most from these treatments. To explore this, I conducted a systematic review of recent studies and found that biological sex matters. Evidence shows that women possess different patterns of PD-1 expression, the very molecule that these drugs target, compared to men. Additionally, hormones like testosterone and estrogen shape how immune cells behave. This could explain why some studies show that men respond better to immune checkpoint inhibitors as a standalone treatment, whereas women respond better when these therapies are combined with a more traditional method like chemotherapy. Obesity also plays a surprising role in therapeutic efficacy. While we often assume obesity may make treatments outcome worse, some studies present a more nuanced view, an obesity paradox. In this, obese cancer patients with preserved muscle mass actually survive longer on immune checkpoints than non-obese patients. These findings suggest that who the patient is, their biology and composition, not just their tumor, can dramatically affect treatment outcomes. So, why does this matter? This matters because women still make up less than 40% of lung cancer trial participants, and obesity is usually only ever treated as a negative risk factor without acknowledging its complex interaction with not only lung cancer cells, but also the treatments as well. If we ignore these effects, we risk designing treatments that only work for the average patient, who may not represent the true patient demographic. By studying sex and obesity as patient intrinsic factors, my project highlights the need for a more personalized, equitable cancer care. I want to leave you with this thought. Treatment must fit the patient, not just the tumor. If we recognize how biology and body composition treatment shape response, we move closer to a world where breakthrough medicines like immunotherapy can work for everybody, not just for a select few. And that's the future I hope my research contributes to. Thank you for your time.